We're going to go ahead and get started. Welcome everybody today to our early intervention echo. We're glad that you have joined us today. I'm really excited about the topic. We are recording this session, so by joining and participating in this, you are consenting to being recorded. We put the recordings up on our website as well as our Canvas site for future viewing and information. We do want this to be an interactive community, so please turn on your cameras, ask those questions that you have, reach out to others on the call. And if you are interested to send in a case narrative, that's a great way to get information from your colleagues, recommendations. So reach out to us if you're interested in doing a case presentation or a case narrative. As always, anytime we're sharing any information, please remember to protect the individual privacy. So don't avoid using any names, identifiable information. If you have any questions, reach out to us or myself or one of the hub members. The hub members all have an asterisk in front of their name. And we just want to give a huge shout out to our hub members. They help us find the presenters, help us make sure everything is running smoothly. If you would take a minute to rename your profile, so putting your name, your discipline, and maybe where you work, that would be a great thing to do. We have multiple states, so knowing what state you're from is always helpful. Sorry, every time I click something else, then my screen stops moving. So once again, how to raise your hand if you have any questions. You can always put those in chat, but you can raise your hand and then we'll also give you a call. Pre-registering for this session allows us to send out those materials, get you that information ahead of time. So you can always do that by reaching out to earlyecho@usu.edu or just pre-registering on the on the Zoom link. To get a credit of attendance, so that certificate of attendance, we really are asking you to return or complete those surveys, and that's then how we send out that certificate of attendance. So thank you to all who always fill those out and have done that in the past. Please take a minute. It's what helps keep these sessions free when we get that information. Canvas is where we store all of our information. So any of the recordings, the handouts, the case recommendations, any of that stuff is on our Canvas site. So if you need access to Canvas, you can email Kurt Phillips or earlyecho@usu.edu. Case studies, again, is just a great way to get information or recommendations from your colleagues and get feedback that you can take back and try with your families or your clients. So if you're interested in doing that, please reach out to us. RedCap is where the surveys will come from. So if you do not get a survey, please check your spam, junk, or email folders to get those surveys. Once again, just a huge thank you to those who fill those out. It really helps keep those free. Following us on Facebook and Instagram. And then I'm just thrilled today to introduce Lauren Ayala. Oh, I've said it wrong, I guarantee. She is our physical therapist from the University of Utah and is going to just give a great presentation on the introduction of cerebral palsy. So I apologize that I've messed your name up, and I'm going to stop sharing and turn it right on over to you.
No problem. You did fine, Janelle. Thank you for the intro. Go ahead and start sharing my screen. And then, oh, I'm not at the beginning. I need to reverse a little bit. Sorry, you're getting a preview of everything to come. There we go. Okay. So as Janelle mentioned, my name is Lauren Ayala. I'm a physical therapist at the University Developmental Assessment Clinics. I have kind of the biggest presence in our neonatal follow-up program, and then also in our Heart Center neurodevelopmental program. I also work in our child developmental program at UDAC. And then I am fortunate enough to be on a grant, which Dr. Betsy Ostrander is the PI. And a lot of work on our grant has been through the Cerebral Palsy Foundation, implementing the international guidelines that were published in 2017 for early diagnosis of cerebral palsy. And so this presentation is kind of a collaboration of the work of all the people you see below. And I'm really excited to be here to present to you guys. So I just wanted to do a really quick recap of cerebral palsy. It's one of the most common physical disabilities in childhood, with an incidence of about 2 for every 1,000. That incidence does increase in high-risk populations, including extremely premature or low birth weight infants, which is a lot of what we see in neonatal follow-up clinic. The clinical diagnosis of cerebral palsy is based on a combination of things. And for early diagnosis of cerebral palsy, the tools that we're really looking at are the GMA, which stands for the General Movements Assessment, the HINE, which stands for the Hammersmith Infant Neurologic Examination, and an MRI or magnetic resonance imaging. And then there are various types of cerebral palsy. The most common is spastic, then ataxic, apoptoid, and mixed. Hypotonic cerebral palsy in some countries is also recognized as a type. And then spastic is often categorized topographically. So it can affect half the body in the case of hemiplegia, diplegia or bilateral, where it affects the legs greater than the upper extremities, quadriplegia, where it's affecting the whole body. And then there are some cases of monoplegia, where you just have one limb that's more affected. Some people argue that that's hemiplegia, where upper is more affected than the lower. And then often we'll have asymmetric quads. Sometimes people will use the term triplegia for those individuals, but lots of different opinions on all of those. And then this slide is just kind of going over our partnership with the Cerebral Palsy Foundation. We've been lucky enough to be part of this collaborative network throughout the United States that involves various sites. Our main site was at Nationwide Children's Hospital, but has now moved to Emory. That's where our main PI for this project is. But it's really, this project started as a collaboration between providers and various stakeholders, including parents, with really the idea and the hope that cerebral palsy diagnosis should happen as early as possible, so that children can get access to specific interventions during their window of greatest neuroplasticity, and so that parents can get the appropriate financial and emotional supports as early as possible as well. And then this is just kind of a screenshot of the paper that was published by Ayala and Novak's group in 2017 that has the guidelines for early diagnosis of cerebral palsy. This is a great paper. Some of it gets really technical, some of it isn't quite as technical. So depending on your discipline and interest, I would definitely recommend reviewing this paper. It's free and open access. So if you just Google early diagnosis guidelines cerebral palsy or Iona Novak 2017, it will pop right up. And then I do have the link to the PDF, which I think you guys have access to my slides. So you can always look that up after, or that's a reference that you can look up afterwards if you're interested. And then I'd just like to jump in a little bit to this diagram that is in the article. It has sort of the breakdown of the clinical tools that are used in the diagnosis of used for early diagnosis of cerebral palsy. So before a 5-month corrected age, on the left side, you'll see that there's the clinical neurologic examination, which is the Hammersmith Infant Neurologic Examination, neurological imaging, which is suggested as the MRI, and then motor tests, which includes, here it says GMs, which is the same as GMA, the General Movements Assessment, And then it has motor performance measures, so the TEMP or the test of infant motor performance. And then above 5 months corrected age, you can still use the Hein or the Hammersmith Infant Neurologic Examination. You can also use the MRI. You're no longer able to do general movements assessment because the infant is too old, but there are an array of motor assessments that you can use as well. So let's talk a little bit about the general movements assessment. It is a standardized assessment. It is a qualitative assessment where you're looking at the baby's general movements to identify infants that are at high risk for neuromotor deficits, including cerebral palsy. General movements begin as early as 9 weeks post-menstrual age, and they continue until they start to resolve around 8 weeks post-term. And so the movements are variable in sequence. They involve the whole body. You'll see movements in the neck, the trunk, the arms, the legs, and they're called riding movements. I think like the best characterization of these movements is when you pull a worm out of the ground and then you set it down and it just like writhes around. So you have a lot of rotation along the long axis of the limbs. It's unpredictable. It has sort of like a symphonic eloquence to it. They should be really kind of beautiful in a way. So these movements come from the central pattern generators. So the thought is that reduction of modulation of the central pattern generators is going to result in less variable movements. So movements won't be quite as varied or quite as beautiful, or you're going to see abnormal movements. And the list of abnormal examples of the general movements assessment are just listed here. So poor repertoire, cramp synchronized, and chaotic. Cramp synchronized is the one that I'm going to talk about the most because that's the one that's most predictive of cerebral palsy or later motor deficits in children. Here is just kind of a diagram that goes over the writing movements or general movements and how they change throughout time. So you'll see the kind of the blue area, that's the writing movements. They start at the 9 weeks post-menstrual age, and then they start to resolve until they completely fade by 8 weeks post-term. So those movements are what we're going to talk about first, and then we'll go on to the next area after we discuss the writing movements. So I kind of already talked about what the slide shows you. I have some pictures trying to kind of characterize the movements that I'm trying to explain, but also when I go back to symphony, think about like crescendo, decrescendo, these movements, they have changes in like speed and amplitude. Sometimes they start fast, sometimes they start slow, but let me just jump into a video example as opposed to talking too much because the visual, at least for me, is really helpful. So this is a preterm writing movements. This is an example of normal, which we call normal writing. It takes a moment for baby to kind of warm up and get going. So you see there's a big variety in baby's movements. Some movements are big, some are smaller, some are a little faster, some are slower. In writing movements, you're also looking for kind of like a continual writing movement. So some of the trainers will talk about it as like the John Travolta, like the arms like coming down like Discovery. You can't see my whole body, but that's what I'm trying to kind of recreate. So this is an example of preterm normal writing. And then I'll jump over to the video on the other side of the screen. Oh, sorry, let that baby finish, and then I'll jump over. The other side shows a term baby that's also normal writing. Once you get to term age, the movements aren't quite as big. Baby's bigger, has more body to deal with. So there's movements, the amplitude isn't quite as large. There isn't quite as much variability in speed, and its movements tend to be a little bit more proximal, closer to the center of the body. And again, these are both examples of normal. And it's really there in that shoulder. You can see that kind of beautiful little rising movement happening. And another way I like to characterize these is you really don't know what baby's going to do next. It's unpredictable. You may see some repetitions, but baby's doing a lot of different things. And you don't really know what baby's going to do next. Okay, and then I'm going to come down. My next slide has an example of abnormal. The only abnormal I'm going to show today is not synchronized, which is the most predictive for the outcome of cerebral palsy. The movement sounds a lot like the name. So everything is firing in synchrony. So baby's kind of doing this synchronized cramping motion. You can see the abdominal muscles are engaged, lower extremities and upper extremities. Baby almost gets kind of like in this stuck pattern. This baby's a little closer to term. Yeah. Sometimes when I watch these videos, or I'm watching a video of a baby with cramped movements, I'll find myself kind of doing a little abdominal crunch, or I find it's harder to breathe. That always kind of cues me that, oh, there's something, this is not normal. You really see the difference between the normal and abnormal. These are very clear examples. Not always this clear clinically. Then we're going to jump to the next period. So that was writing. Writing is followed by the fidgety period. So that's the kind of darker brown area that you'll see on this timeline. So the fidgety movements can begin as early as about 6 weeks post-term age, and they continue until about 20 weeks post-term age. And then voluntary and anti-gravity movements really take over, and those fidgety movements resolve. We do see that there is overlap between voluntary and anti-gravity movements. So sometimes that can make observing fidgety movements a little difficult because there is overlap between the two. So the fidgety movements, what they are, they're continuous, tiny little movements of the joints. So you'll see them at the neck, the trunk, wrists, ankles, hips, just everywhere, and they should be continuous. The time that's easiest to observe these movements is between 10 and 16 weeks post-term age. They're small movements. They should be a moderate speed up to fast, multi-directional. You should see them proximal distal, as I mentioned. They're also going to be co-occurring with other movements that you see here. So baby, really wiggly babies, it's hard to observe these, but when a baby is kind of calm and at rest, kind of relaxes, especially at midline, it's really easy to observe these movements. And then if baby's not engaged with someone, it's also easier. So the absence of these movements, we expect to see these movements, it's normal. The absence of these movements, or these movements are very rare during this period that I've mentioned. The infant is likely to develop a severe neurological deficit, such as cerebral palsy. Here are some examples of normal. These are normal fidgety movements. Baby's got some nice foot to foot and hand to hand. And when baby does that, you can really kind of see those little movements, such as in the shoulders, C-spine, the ankles, the hips. But it's almost like this little dance that's happening in the background. And just the other day in clinic, our neonatologist was describing it as, you know, you just think of a cute little happy baby, and that's there's fidgety movements, these tiny little motions. And then this is another example of normal below. I know our top video is still playing, but I'll go ahead and start the bottom video too. You can see really nice in the ankles on the lower video, how babies kind of got that foot to foot play, and you can see those continuous multiplanar movements in baby's ankles. Those are some really nice fidgety movements. Again, if someone is really visually engaging with baby or talking to baby, sometimes you don't see these movements as well. So it's better for baby just to kind of be in a calm, relaxed state, which is easier said than done sometimes. This is a really nice example. You should be seeing them on both sides of the body. all limbs. Okay, now let's jump to the next slide, which has an example of, is an abnormal example, so absent fidgety. This baby is still exhibiting lots of movements, but you're not seeing those fidgety movements or those small movements happening at the joints, those little multiplanar continuous movements, which is really not there. Baby's kind of moving everything in large, kind of like as a block. And so this is the movement that, this lack of that type of movement, absent fidgety or the lack of fidgety movements is concerning and the most predictive for cerebral palsy. Okay, and then getting a general movements assessment is really easy. You just need a recording device. That can be an iPad, iPhone, anything that will do video recording. Baby needs to be in a supine position. You can be able to see the entire baby from that bird's eye view. For fidgety, the term and above baby needs to be awake and happy. Preterm baby can be sleeping because baby will cycle through general movements. So there'll be movements where babies aren't moving, but then they'll cycle and come to a general movements, and it can be filmed during that time. Video should be about 2 minutes long, and they have to be read by someone that's been trained by the General Movements Practical General Movements Assessment Trust. The 3 to 4 day training, and you have to pass a test at the end to be considered certified. And then below it just says things to avoid when you are doing the General Movements Assessment. I like this slide because it just kind of shows trajectory for the different types of general movements. Mainly what we've been focusing on today is just looking at the abnormal examples or ones that are most predictive for cerebral palsy. So that would be during the preterm and writing period, the cramp synchronized, which most often goes to or progresses to absent fidgety movements during the fidgety period with an outcome of cerebral palsy. We clinically do see lots of variations, but just for time's sake, that's kind of what I wanted to focus on today. And then this is just going over results from a systematic review of the predictive value of the general movements assessment. So cramp synchronized movements in a near term and during the term period combined with absent fidgety, AF movements during the 3 to 4 month corrected age period is very predictive of cerebral palsy. And then below you can see the sensitivity and specificity of each of those periods in their predicting cerebral palsy. So they're really, really great tools when used correctly. And then I'd like to jump to the Hein or the Hammersmith Infant Neurologic Examination, which is another tool. I recognize some names on the list for people that have participated in our Hein trainings. We usually hold it 2 a year and open them up to various groups, including early intervention. So it's no cost training. If you haven't been to one of your PT or OT in the early intervention setting, reach out to me or let's connect, especially if you're out of state. We've had one person come from Wyoming, but everyone else has mainly been in the Utah area so far. So the Hein is a standardized quantitative neurologic assessment. It can be used on infants 2 to 24 months of age or corrected age, whatever applies to baby. There's 26 different items. Each item is scored 0 to 3. Global score is 0 to 78. And then there's also an asymmetry score, which is important in detecting risk for, especially for babies with hemiplegia, cerebral palsy. And then below, you'll just see the cutoffs that we use in our neonatal follow-up clinic. Those cutoffs help us determine children that are in the at-risk category for cerebral palsy. And then this is just referencing the paper that those cutoffs come from. And here is a slide that has a table of the different cutoffs. If you use the Hein or want to use the Hein, this is a great reference, and you can really kind of look at the cutoffs for different populations and pick the cutoff that matches the population of the child that you're seeing. In neonatal follow-up, we use the very bottom one because the population is NICU, including preterm and term babies. This just shows a prognostic tool from a paper based on Hein scores of infants between 9 and 18 months. These are preterm infants born before 31 weeks gestation. So that's the group that it applies to. So for infants greater than 9 months, falling between these scores, we have prediction of severe neurological deficit, which includes cerebral palsy, in the score range that you see for the bottom figure. And then prediction of sitting at 2 years for the range that you see for the yellow infant in the middle, and then prediction of walking at 2 years for the one at the top. So this is really valuable, I think, when you're talking about prognosis and therapy goals for children, and also planning for equipment. And then I'd just like to jump into a paper that was published by the network that we are part of. So in our first year of implementing the tools for early detection and diagnosis of cerebral palsy, that included doing the general movements assessment in a few of our NICUs, and then also in our neonatal follow-up program, the Hammersmith Infant Neurologic Examination, and then MRIs were already happening, but continuing to do those. We were able to lower the average age at diagnosis significantly, and you can see kind of the progression between the first 3 trimesters of implementation. So baseline was at about 19.5 months was the average age of diagnosis between all of our sites. Utah's was a little higher than the group. I think Utah we were 22 was about our average. And then by the end, between all of our sites across the nation, the average age was 9.5 months. So we were able to significantly lower that, which is really exciting. And then I'd just like to touch on, yeah, I'm still good on time. Okay, I'd just like to touch on a little bit of parent perspectives. I think that's really important and really relevant to this group. And so this is just looking at some papers that are now a little bit older, but going over parent benefit of early diagnosis and also the possible harm of a delayed diagnosis. So older research really has demonstrated that disclosure of diagnosis of CP is a really momentous period in a family's life, and very transformative in many ways, good and difficult ways. There were also 2 studies previously published that showed parent dissatisfaction with timing of diagnosis. Now these were published early 2000s, so that's changed now. But in those papers, about 40% of mothers interviewed in one study reported that CP diagnosis was delayed, and that was cause of frustration or dissatisfaction. And so in the paper that I referenced before, looking at the first year of our implementation across all the networks, we also did some parent surveys with that. And so these are just the parent metrics from that survey. Overall, they're definitely very positive, but some things that we learned from that was that often parents wanted more information in different areas, and they wanted information that was easily understandable. But I think overall our feedback from parents was positive. It did give us some areas that we can improve in. I think those, I'm going to come to some slides that kind of go into a little bit more details about that. And this paper is older than the one I was just referencing, but it's a really interesting paper that was done, kind of qualitative assessment, so doing parent interviews and getting groups together. I think they interviewed about 17 parents who had received cerebral palsy diagnoses, and there was a variety among the parent demographics and that were included in this group. But parents' priorities on how the diagnosis was communicated was that they wanted there to be a positive tone and it to be hopeful. They wanted language to be simple and then become more complicated as parents are asking for that information. And then they also asked it not to be too general. They wanted it to be as specific to their child as possible. But I think the biggest thing to take away was be honest. I love this one in kind of the top left-hand corner for tone, a positive tone. Be honest, realistic, and hopeful was the quote from the parent. And I think that's really important and sometimes difficult to be honest about concerns up front with parents because we want to protect our parents. But in the long run, I think it not having the honest part really does cause harm and distrust for parents. And then coming down to the next one, looking at parent priorities on neuromotor diagnostic tools. So these are ones that really apply to any providers that are doing diagnostic tools in the home or assessments, since this is mainly early intervention group. But I thought this was helpful for me to hear as well. But naming the purpose of the test, explaining the purpose of the test to the parent and what you're doing, whether it's videotape or just observing baby, and then providing brief descriptions as you're doing the exam, and then a summary at the end. And then this goes on to predicting outcomes and parent priorities. So again, parents really want a positive tone and want you to help foster their hope while still being honest. So really emphasizing brain plasticity, you know, when children are given the diagnosis of cerebral palsy, and focusing on the things that therapy can help them achieve, and taking that positive tone and really focusing on what we can work on, and leaving room for that hope is really important. And then also parents didn't want their child's outcomes to be compared to others. They also asked for didn't want their child to be compared to typically or expected development, and looking at the impairments or the trajectory of their child in comparison to that. And then also they really wanted to know the evidence that's used for predicting their child's outcome. So understanding the assessment, having it explained, and then the evidence upon which the prediction is being based, which I think is really important. So when doing that for families, it's really important that we understand the evidence and the limitations of it and what it does tell us. And they were able to explain that clearly to parents in a way that's easily understandable for them. This is just a slide to intro kind of into our neonatal follow-up program here in Salt Lake. We do cover the Intermountain West, so it's a huge area. We see some patients in Montana, we see some Idaho patients, we've seen a few Colorado patients. Every once in a while we'll get a California, we see Nevada patients. So it's really a large area. And I think one of the benefits of the pandemic was being able to convert the assessments that we're doing to a telehealth model. So that really opens things up and makes it a lot easier for our patients that are farther away to be able to access our clinic. So this is our kind of in-person schedule and assessments. And then this next one shows how we converted that to a telehealth model during the pandemic. And we're continuing to offer that even now. So it's still an option for our neonatal follow-up families. So if you do see our families, just know, especially if they're far away, that telehealth is an option, and to let them know that if that distance is a barrier for them. And then if you do have questions about creating your own telehealth models, I'd love to chat, because it was definitely a learning curve, and if we combine together, we can share great ideas. Let's go to this video. And then I don't want to spend too much time on this slide. This is just kind of looking at our local Utah numbers when we implemented this project. So we've been doing this for about 4 years now. And these are our numbers divided up by each year. So it kind of shows how we were able to continue our project even during the pandemic, which was difficult, but it was possible. So we're looking at the number of general movements assessments that we did in our NICUs. The first two numbers really reflect just the University of Utah NICU and Primary Children's NICU, but then we added Intermountain Medical Center. And right now we're expanding to McKay-Dee and Utah Valley Regional Hospital. And then we were exploring St. George Regional Hospital, but that's kind of on hold for now. And then we're also, you'll see our numbers for general movements assessments in our NFP program, the number of visits that we had in the NFP program, the number of high-risk diagnoses for cerebral palsy that we made each year, and then the average age of the children when they receive that high-risk diagnosis. Then next is the average age of cerebral palsy diagnosis, and then total number of CP diagnoses each year. And then below, I think this one's interesting, general movements assessments that brought in children into the NFP program. that weren't otherwise qualifiers for NFP. So catching those cramps synchronized in the NICU for babies that wouldn't otherwise see us in the neonatal follow-up program. And then, okay, so I have a few minutes. I'd like to talk about some really exciting projects that are going on right now. So with implementation of these tools for early diagnosis of cerebral palsy, now we have more children below the age of 2 that are receiving this diagnosis. And we don't, the research is very slim on what are the most appropriate assessments and interventions for these babies, and really knowing what works and what tools are validated to measure change in these babies. So we have a lot of tools for older kids, but we don't have validated tools for younger ones. So this is one study that we're doing among multiple sites. Utah is participating in this study. It's trying to validate parent questionnaire looking at sleep, so a sleep assessment. That's an exciting one that we're working on right now. This is a study out of UCLA looking at movement for children that are high risk or have a diagnosis of cerebral palsy. It's really interesting. It's been led by Eileen Fowler, and it's done through Zoom. So if you have families that would qualify for this, feel free to share the information, because anyone can participate, since if they can connect to Zoom, they can participate. It's a really interesting study that Eileen's working on. And then this one that I think is really exciting, and hopefully we'll have positive results and have a big impact in our rural communities, is looking at a pressure mat that we would put under baby in the NICU to detect the cramp synchronized movement. Currently, to get certified in the general movements assessment, you have to do this. You have to travel, and you have to go to a 3 to 4 day course, and it's expensive, and it's not really feasible to get everyone in the nation at every NICU and every neonatal follow-up program certified in this study. And then one difficulty for people out in rural communities is that you don't really have a group or a team of other people that are trained to kind of bounce things off of, which can be difficult for maintaining fidelity. So this is looking at kind of taking out the human equation, at least in the NICU or the riding period, and being able to catch a cramp synchronized baby through this pressure pad. It's the same type of pad that you would use for like a spinal cord patient, like doing pressure mapping for seeding. So that's a really exciting one that we're starting at the University of Utah NICU, and then hopefully soon to follow at the Intermountain Medical Center. And then this is one that we're doing here at UDAC. It's called the Apples Tele Research Study. This one's really exciting. So it's looking at children that have asymmetries, that have a diagnosis of cerebral palsy or at high risk for cerebral palsy. Children can be qualified for the study between the ages of 3 to 13 months, chronological or adjusted, whatever applies for the child. And it's looking at 2 different programs. So each program is about 6 weeks. One is kind of a constraint-induced program, really working on improving their weaker side. And then there's also a parent support program. So children are randomized into one of 3 groups. The first 2 groups, you do both therapy programs and the parent support program in different orders. And then the third group is just business as usual. And then we follow it by offering the family to participate either in the parent support program or the therapy, the kind of constraint model. This is done via telehealth. So we have some families that have contacted us from San Francisco area. We have a family that reached out from Denver. And then in Montana, we just started recruitment. So we're trying to recruit babies locally as well. There are 3 in-person lab visits, but all of the therapy visits are done via telehealth. So it's a really exciting program. So keep that in mind for some of your babies, and you can send them to us if you think they qualify. So let's see, I think that was the last study. So some really exciting studies looking at assessments and interventions for this group. It's a really exciting field. I could talk on and on, but I'm trying to stay brief because Kirsten has a really exciting stuff for the case report. So I guess I'll open the floor to questions. If there are any questions, I'll let Kirsten take over. I don't know, Janelle, is that the right?
Yeah. So if you will leave it open for a few questions and answers for a few minutes before we start our case presentation. So you can either put your questions in the chat and we can monitor that, or you can just come unmute and we'll ask those questions if anybody has them.
And Janelle, while we're waiting for questions to come in, I think multiple times I referenced like, hey, reach out to me if you are interested in any of this or you want to connect, but I didn't provide my email on the presentation. Would you be able to share my email with the group?
Yep, I certainly can, or we can also even put that into the chat right now.
Sure, I can do that.
So I'm trying to, I don't see anyone off of mute yet. If you have any questions.
When is your next Hein training, Lauren?
Oh, that's a great question. So we actually have one next Wednesday, a week from today. Our limit on slots is 15. We currently have 9 registrants, so there are still 6 slots. If you are available next Wednesday morning, the training goes from 8 to 12, and then there's the optional informational session after 12, which is pretty similar to the presentation I just gave, so you probably wouldn't need to attend the optional information session. So email me if you're interested. Our next one will be, we usually do 2 a year. Our next one will be in September. I usually send an email with the flyer and the registration information a few months before to the early intervention directors. So and ask them to just pass it on to their therapists. So save the date for early September. I can't remember the exact date in September, but our next one will be September. Oh, and I saw Kurt's comment. Thank you about, yeah, you came to our Hein training about a year ago. Yeah.
Yeah, it was great. There was a few of us from up here, and Logan that traveled down. It was really informative, really great. I've been doing therapy with kids now for over 20 years and still learn some good stuff. So thank you for putting that together.
Of course, it's a really great tool. And I think it puts a number to your worries. So if you're going to refer the child because you're worried about their neurologic status or you're worried about possible cerebral palsy, it's just a great tool because you can, instead of saying, oh, I'm worried and XYZ, this is what's going on, you say, this is your Hein score, which is really powerful, especially if you're doing the referral to neurology. So it's really great in that sense as well.
Danson, it looked like you had your hand up.
Yes, I just had a question. If we're not trained in the Hein or the GMA, but we are receiving referrals that include monitor for signs of CP, I'm always kind of unsure of what specifically we should communicate back if we don't have these kind of numbers or scores. Like if we're concerned, if we're seeing signs and they're doing, and the children or the child is doing follow-ups, regular follow-ups with the hospitals, I guess I'm not quite sure what other information to send with the parents or to send to the physicians. Does that make sense?
Yeah. What's your specialty?
Oh, sorry. I'm a physical therapist, early intervention in Idaho.
Oh, in Idaho. Okay. Where in Idaho are you?
In Pocatello, Idaho.
Pocatello,
But
okay.
I serve the central and southern regions.
Okay. So that's a really great question. And I think a lot of it depends on therapist comfort level, but you're asking kind of what to say to the physicians that you're referring them to, or what to communicate to the family? Is that your question?
Yes, that's my question. And also, it just seems so open-ended, monitor for signs of CP, and I'm not sure at what point we would say yes, or even recommending like one of these assessments would need to be done by somebody trained.
Yeah. So honestly, my thought is the early, like as soon as you have words, the earlier the better. So referring them to somewhere where they do have these tools, or to neurology, if you're worried about cerebral palsy, referring them to neurology, or like if they would qualify for a neonatal follow-up clinic, I would say the sooner the better. And then the tools that you are comfortable with, or that you do have, that if they do kind of catch that worry, also providing, that standardized tools, providing that data for the providers, and then just being honest with the family about your concerns, and just describing them within your scope as a physical therapist, like what you're seeing and why it's concerning to you, and that they should have follow-up. Some parents are really savvy, and as you start describing, you start to, I'm worried about muscle tone and worried about this motor delays, and parents, like CP. And so some parents will already make that connection and say those words, but I've had some families come where they say that their therapist sent them to our clinic because their therapist is worried about cerebral palsy, but other therapists don't feel comfortable saying those words. And it's tricky too, because sometimes you'll say that you have that concern or bring that up, and then parents connect it to CP, and then they think their child has CP, even though you haven't said that. So it's tricky. That's a really tricky question, but I think the most important thing is staying within the scope of your practice and being honest with parents from the beginning about your concerns. Does that answer your question, Danson? I don't know if I stayed too general, but.
Yes, that really does help. I guess I do get confused on families who are already part of a follow-up clinic and are already seeing a neurologist. What additional things to monitor for, I guess, or if that's just something that's noted on the documentation, but that they're monitoring and following up, if that makes sense.
Yeah. Which neonatal follow-up program is it ours, or is it one in Boise that you often?
So I shouldn't say neonatal follow-up, but several of the families are already part of a team at Primary Children's Hospital. And so they'll have their neurologist within that clinic. They say they go to follow-up clinic.
Yeah, which means so many things. There's so many different
Yes.
follow-up clinics. And so it's hard to know if we're one group within that system. And it's still trickling. So there's very like they could be followed in the feeding follow-up clinic, or they could be seeing neurology, but it's not the neurologist that's in the neonatal follow-up clinic. That's the PI, or the one that's really been spearheading this project. And so I gave you our numbers of how early we're diagnosing, but I wouldn't say that everyone within the primary children's system or the university system is doing it that early. It really, implementation takes a long time, and trickle down takes a long time. So finding out exactly which clinic can really help enlighten. And if you do see patients that go to our area, you're always welcome to send them to UDAC, because we use all of these tools and frequently do early diagnosis of cerebral palsy. So if you're are you familiar with our program?
I have had a couple of families that say they were then referred to UDAC. So this is clarifying things up for me. This is really helpful. Thank you.
And then there was another question. If you are worried about CP, where would you refer them to get a diagnosis?
That's a great question. So I may be a little biased here, but I would, if they qualify for neonatal follow-up clinic, send them to us. If they don't, you can send them to neurology, or you can send them to, within the UDAC program, we have something called Neuromotor Clinic that's run by Dr. Sarah Winter. And she sees, in that program, we see children with early motor delays. And we really see a wide range of kids, but we frequently will make cerebral palsy diagnosis in that clinic. So my bias would be sending them to us or neurology if you have that specific worry, and they can make it into UDAC, which is that outpatient Eccles building in Salt Lake City. But there are other places. That's just the one that I know the best because I'm here. But, and then looks like another question.
Yeah, and so then Pat says, what other states or centers are using the GMA in their NICU follow-up clinics?
That's a great question. There are a lot of programs that use it. So within our network, There's Children's Hospital of Philadelphia, CHOP, Kennedy Kruger Institute, Johns Hopkins, Lurie Children's in Chicago. And there are other programs in Chicago that also use the GMA. They have a lot of trained people that are trained in the general movements assessment in Chicago. I know that University of Texas in Houston was, I don't know if they still are. And then UCLA also has a program. Those are the programs I know about through our network, but there are lots of other programs. I know there's some, at some of the trainings I've met therapists at Tennessee. I've met some in Denver. Did you raise your hand, Pat? Do you know of more people?
That means I have to unmute. Yeah, because when this all got going, it was Europe. It was, and when you look at the research and the follow-up, it's all Europe. And then
Australia
from Australia. But I think my opinion is this needs to take over as a diagnostic tool. And yeah, that's it. It needs to be taken. And it's such a simple process.
It is, and it's so, you know, all the places you're naming, or most of them are places that have socialized medicine, where it's so much easier to kind of implement a standard. It's so hard in the US. We're really fractionated, and so
yeah, it's universal health care.
Yeah.
Coming from Canada, we don't call it socialized.
Yeah, I'm sorry.
No, I know. I mean, and that makes it so much easier. But this saves money, and I think that would be the motive for our U.S. healthcare system, is it saves money, and especially somebody from, you know, you're talking about St. George. And yeah, I mean, if you can just video the kid and then look at the kid, and then you have so much more information. You don't have to ship them up to primary children. So yeah, that's my simple opinion.
Yeah, and we have been able to see a good number of kids in St. George via telehealth, which is awesome, and it does allow us to get the GMA. But we're still working on getting the GMA at the NICU down there. It's a process. Everything's a process.
That's right. Everything is a process. Thank you very much for all that great information. I think you're staying on as Kirsten goes through her case presentation. So Kirsten, if you want to just share your screen, and we are going to stay in a large group as we go through this case presentation, so everybody can participate in that.
And thank you for that lead in on saying that it's a process, because that's exactly what I want to talk about today, is processes. So that is perfect. My name is Kirsten Ahlberg, and I'm a physical therapist, and I work at DDI Vantage in the Salt Lake Valley. And I've been with DDI for almost 14 years now. So let me see if I can get my, hang on. Oh shoot, it's not showing my presenter view. Hang on. So Janelle, do you still just have my big slide, or did it go to my notes?
Just your big slide.
Okay, perfect. So I'm going to start with our community discussion slide first. So this case is going to be a little bit different. Rather than go through a single case and ask for suggestions, I want to talk about processes and look at this from a systems perspective. So I will use a single case example to illustrate an intake process in our service decisions for a child who is identified as high risk for cerebral palsy. And just before, hang on just a second, got to fix my screen here. Okay, so I've been really fortunate that I had the opportunity to attend some of the meetings with the neonatal follow-up and the NICU staffs. And listen to them talk about their conversations about how to develop their processes. And I was able to provide a little bit of EI perspective for them, but then also bring back a lot of the information I got from them back to our agency to work on our process. But we don't have a perfect process in place still. We're still looking on it. And I know that not everybody here has the same resources. And so the reason I wanted to stay together as a whole group today instead of going into breakout sessions is I would just love to hear about how things are different in different states. Do we have some similarities in our process, or how are things different, and what works and what can we improve? What barriers, there's definitely, the further rural you are, you're going to have more barriers. I'm very fortunate to have the neonatal follow-up program practically next door. But there's also a lot of facilitators now with our telehealth and whatnot. So I want to be able to talk about that and just learn from each other, because I see this, as Pat was just saying, that this is really going to become the standard of care. This is where we're moving with CP, is that we're going to start identifying them early. We need to, and we need to get them into early services and early appropriate services. And so I want us all to learn together as we are going through these changes on how we can improve that. So that's what this case will be to illustrate. So I made up a nickname for this kiddo. I'm calling him Awesome Kiddo. So that's what the AK stands for. And this little guy was born at 27 weeks and 5 days. So he was born shortly before COVID vaccinations became available. So mom had gotten COVID and developed placental blood clots. And he was found to have poor fetal heart tones and poor fetal movement. And so they did an emergency C-section at 27 weeks and 5 days. His birth weight was 1,005 grams. And then he had an MRI right around term, and he had grade 4 on the left, and on the right, grade 3 intraventricular hemorrhages. And so for those of you that aren't familiar with grading of IVHs, it goes on a scale of 1 to 4, with 4 being the worst. So fairly significant IVHs for him, or brain bleeds. And then he had some hydrocephalus associated with that, and received a reservoir when he was about 3 weeks old chronologically. And he did not have to move on to a shunt, which was good. He was also diagnosed in the NICU with delayed visual maturation. He was noted to have high tone. And then on his general movement assessment, he had a poor repertoire. So that's not as bad as the cramped synchrony, but it still is an area of concern. So he qualified to participate in neonatal follow-up program. And in Utah, we have an auto-qualifier list. And so this child actually qualified on his delayed visual maturation, but also we have this special list for kids that are in the NICU. So if they meet any of these bullet points here, they qualify for 1 year of services automatically. So it doesn't matter what their testing shows. And then after that year, when we are requalifying them, then if they have been given another diagnosis, then we can requalify on that, or we can requalify on testing or on clinical opinion if needed. And so this little guy fell into the second bullet point down, which is the extremely preterm. The top bullet point, he just barely came in over that 1,000 grams. He was 1,005 grams, if you remember, but he was born before 28 weeks, so he is extremely preterm. And so he qualifies based on that being extremely preterm. And I would love to see this list in the future contain either something like high risk for cerebral palsy or abnormal movement, so as we start to bring in this research that's being done, recognizing that these movement assessments are a really good way for us to tag this early. And I would love to see that be an automatic qualifier for these kiddos, at least for that first year. So our intake process is he was auto-qualified for services. The delayed visual maturation did not make it into our online tracking system, but he was qualified on the NICU grad for being extremely preterm. And then he started services immediately with a nurse and with our parent infant program vision services for that delayed visual maturation. And he was also receiving home health, PT, OT, and then SLP for feeding as well. And we try to provide a motor therapist anytime we have a documented brain injury, or if we know that we've got concerns from the NICU on the child's movement. And so we did not have a PT available to go immediately to the initial IFSP meeting, but sometimes we'll have the first service provider just write a consult immediately. In this case, we knew we wanted PT for this child, so I just went a little bit later as soon as I could get in and coordinate my schedule with the service coordinator and the family. So I was added about a month after services started, but we got going pretty quickly with the motor therapist for this child. And that's just really part of our process over time. We don't like having a child that's got a documented brain injury and waiting for somebody else to pick up on really obvious motor delays. We want to be able to see some of these really subtle things that Lauren just showed us today. So we try to get a motor therapist in if we know that there are concerns for that. And information that we've received from the neonatal follow-up, I did just get a couple of updates yesterday after I had these slides already sent over. So at 4 months adjusted, at this child's neonatal follow-up visit, his Hein score was 54, which put him definitely in the at-risk category. He had jerky movements, and there were some asymmetries noted as well. So he was determined to be high risk for CP, which we already knew from his NICU documentation. And then he did another follow-up at 6 months adjusted. And again, it was noted that he still had high tone. His gross motor and fine motor skills put him at about 5 to 6 months. So he's still falling in the average range as far as the skills that he's doing, but his movement quality wasn't quite there. And he was still determined to be high risk for CP at that point. And then he went back again at 10 months adjusted. And at that point, his gross motor and fine motor skills were at 8 months. His Hein score put him still at risk. And I think he was at a 61 here. And so Lauren showed us that little slide. So he's right around that cutoff that maybe he'll walk by 2 years of age, just right below that cutoff there. He was still noted to have high tone there, and he was given the official diagnosis of CP at that 10-month adjusted age visit. And then he did do another visit at 12 months, and everything was still consistent there. And it's noted that his cerebral palsy is spastic quadriplegic. And so his current function, he's about 17 months chronologic now and about 14 months adjusted. And he crawls in hands and knees for his mobility. He transitions in and out of sit independently and easily and frequently. He pulls to stand and he walks along furniture. He does still have high tone. He's got solid ankle foot orthoses because he was doing a lot of toe standing and starting to get a little bit tight in his ankles. And so that's been helping him to maintain his ankle range of motion and to maintain full foot weight bearing while he's standing. He actually now he does a couple of hours, a couple of times a day without the AFOs, and I usually see him without them, and he is able to keep his heels on the ground when he's doing his cruising along furniture. And his movement is still, he's got some pretty good skills. He's on the low end of average as far as if we look at him from a motor milestone, but his movement's not super high quality. He's still a little jerky and not real fluid. And as PTs, we like to look a lot at their variety of movement, and his variety isn't really horrible. I wouldn't call it poor, but it's also not really what we like to see or what we do see in typically developing children. So I'm calling it fair variety. So he can adapt a little bit when he's got a unique motor challenge, but it takes him a few tries and his movement just isn't super fluid. He's got a fantastic family. Parents are professionals. They both work, but mom just works part-time, so she's home quite a bit with them, and she really follows through on stuff, has great questions and great things to add to the conversation all the time. And he's got 2 older siblings who are very rambunctious with him and provide a lot of stimulation for him. So I'm very confident that this child will walk independently. And we use a gross motor function classification system. So I'm confident that he will be a level 1, which means the least involved. And that also means that he should be able to walk without restrictions, but his movement will never be as fast or as smooth or as coordinated or as energy efficient as his typically developing peers. So I want to talk just a minute about the benefits of having early motor therapy in there. And it's not just me, because they had home health and now they're doing some outpatient as well. But very early on, we look a lot at tone management and how can we position these kids or do some weight bearing or teach them to self-regulate, just things that are going to influence their tone a little bit before they get to the age where they might start managing that with medications. And that can have a really big influence on their ability to start to develop selective motor control, which is when we saw those cramped synchronies, that's not selective. But then you start seeing the more individual movements, and that is more of our selective motor control that we're targeting, trying to accomplish with these kids. We have better acquisition of motor skills because we're able to really break down these tasks into the little tiny baby steps and make it appropriate for the child so that he can work towards acquiring those motor skills. And then I have a really big emphasis when I see a child on really encouraging that movement variety and trying to get that selective motor control, which involves a lot of trunk and core stabilization, but then also really getting that variety allows them to start to choose from a wider repertoire of movement. And so that's something that we need to start looking at and really addressing from a very early age. And then also we've been able to manage his range of motion up to this point, and we really want to prevent those really tight muscles that turn into a contracture and really optimize their musculoskeletal development and their musculoskeletal health. So there's a lot of things that happen with the muscles, and then the skeletal system doesn't get the same input and strengthening and development of some of the joints. And so there's a lot of things that as PTs that we're really trained on to be watching and thinking ahead and really trying to be very proactive about things rather than waiting until there's a problem. And Lauren did hit on the neuroplasticity. Everybody here knows that those first couple of years are super important for neuroplasticity. And so really getting this early diagnosis allows us to take advantage of that. We don't yet have a huge amount of research of very, very early therapy for these kids because it's only been a few years that they've been getting diagnosed young enough to start to do some of this research. And so if you're super skeptical and say you're going to wait for the research, I would advise against that because we do know that plasticity is there. But just another way of looking at this too is what we do know from our natural history is that 90% of motor skills are developed within the first 3 to 5 years in children with CP. And so that level 1, that's the highest level of functioning, they usually continue to gain skills at a pretty rapid rate through about 5 years of age. And then it gets a little bit slower. They keep generally gaining skills till 7 to 9 years of age, and then they tend to plateau. But most of those skills are really gained in those first few years. And for level 5, that is the lowest level of functioning, they gain 90% of their motor skills by 3 years. So if we wait till they're 2 to diagnose them, we are losing half of our intervention opportunity. And so it's just really, really critical that we get these children diagnosed early and get them into motor therapy and not just wait until we're seeing a bunch of really obvious concerns. I almost just took the primary area of concern slide out because we're not actually talking about this child as a case, but obviously we still have concerns with motor and his tone. We are having concerns with language because he's not quite picking up language where he should, and oral motor. So we've got a speech therapist coming in soon for him. And then of course there's the vision. He's got the delayed visual maturation diagnosis, which, he shows a lot of signs of cerebral visual impairment, but he's responding very well to the vision work that is being done. But along with that, there's a lot of very similar behaviors with CVI that we see also with autism. And so there's a very slight question, should we be watching for autism with this child? And yes, always we should be watching for autism. So that's something that is on the radar, but not a huge concern just yet. So just to refresh my thoughts on how I wanted to talk about this, but I'm open to whatever anybody else wants to discuss on this, is how is the process similar or different from your agency or state? What works and what can we improve? And what can we learn from each other? And how can we make some changes as this becomes the standard of care? and then barriers and facilitators. And I'm going to stop my share rather than leave that slide up, except for I'm going to take a picture of it real fast because I won't remember otherwise. So I want to be able to see everybody's faces. So there's my screen share stop. And thank you. So what questions do we have first? Any clarifying questions or thoughts?
So one, Kirsten, is Bailey and Kate are going to kind of take notes together. And then if anybody puts anything in chat, that is how we will come up with our case recommendations.
Okay, awesome. And yeah, it's kind of different because it's not really a case recommendation. I just want to know, we're hearing, from Danson in Idaho about, how do I do this here? And if you're someplace rural and you don't have a neonatal follow-up program close by, how are we gonna make this work as we move forward? Because this is a process for all of us. And Lauren's group, the neonatal follow-up program, has really worked on their process to start to be able to implement these assessments and move this forward, and now working on expanding out away from the urban centers a little bit. But the other part of the equation there is not just identifying them, but we also have to start providing the intervention, and that's the whole point of this identification. So how do we make sure that these kids are getting to the getting their early intervention in the first place, but also getting the right type of services for them? Because I feel very strongly that if the child is diagnosed as high risk, they should be seen by a motor therapist, so OT or PT, if at all possible. So we've got some comments in the chat.
So does anybody, I think we heard about, Kirsten did a fantastic job of how DDI uses or looks at these particular children. How about anybody from any other states or any other agency, like Jordan? I know Jordan is a service coordinator in up to 3 in Logan. This is always the bad thing when I call people out. Jordan, would you say that up to 3 does that process differently or similar?
That's a great question. I think it could be it is very similar, but it's also, every program is going to do things a little bit differently. A lot of what we do is those high risks and those potential things that we're seeing from testing and things that way. But a lot of times we still focus a lot on other team members that are seeing and meeting with the family and the child too. Of course, if we have a diagnosis or anything like that is conclusive, we definitely do try and get someone in there that is related to motor that can help out with CP or anything like that. But that could also just be me as a service coordinator, where I tend to kind of rely a lot and fairly heavily on the other team members that are visiting with the family as well, to kind of get their input, as well as working with the family to decide what services and who should see the child.
Great. Mary, I can't tell where you're from, but you are asking, what is this new process? And I don't know that we have it, that it's necessarily a new process. I don't know if you want to come off mute and ask your question. I can't see you.
Well, I felt bad because I missed part of this. I was still seeing kids because I'm traveling today to Tooele to help cover. And so I missed Lauren's presentation. So I missed the first part of it. I don't know if she went over like the Hammersmith or what things are guiding their early diagnosis of CP.
Yeah, so we did that's what Lauren did talk about. And then Kirsten's presentation or case discussion is just how do we all from different states or different agencies work through the process of early identification. So
okay, I guess I worked in outpatient for a long time, and our process, whether we saw them birth to 3 or older, if they didn't have, because there were a few kids that didn't have diagnosis, we would just refer them to rehab medicine to get a diagnosis, I guess. But are you talking about our screening as therapists?
Any of it. That's what we're just kind of trying to brainstorm, Kirsten, right? Is how everybody does it, because everybody kind of does it a little bit differently. And can we learn from each other, and what are some of the barriers, or can we change some things to help that be more of a standardization of care?
Perfect summary, Janelle.
Yeah.
It's always hard. And it looks like Abby from North Dakota, I don't know if you want to share how maybe your state.
So, and yeah, I was just going to read Abby's chat message. It just says our criteria for auto eligibility are similar. However, when a kid qualifies for our program, they are in until they turn 3, regardless of if they catch up or not. So yeah, that's interesting. In Utah, we have, they have to qualify every year. We can always qualify on a clinical opinion if their standardized testing looks good. So we have a hierarchy. If they qualify based on a diagnosis, that's our first choice. We're supposed to qualify them on that. And then our second choice is to qualify them on standardized testing. And then our third choice is to qualify them on clinical opinion. So, but they do have to requalify every year for services. So. But it's pretty, basically, if the family wants to continue, we say, okay, if they have concerns, we value those concerns. And so we usually will continue with them if anybody on the team, including the family, has concerns.
So Kirsten, is the goal then to have these kids get that CP diagnosis early, not just for qualification, or is it mostly just to qualify for our program, or what's your thoughts on that?
My thoughts on it are to identify early so that we can make sure that they're getting appropriate services, so that we can take advantage of that window of plasticity and that window of time that they're going to be gaining motor skills, and optimize that as much as possible. And so,
yeah, I agree with that 100%. I went to the training for the Hammersmith last year. It was the second time I've had the training, and it's an extremely helpful assessment tool for early identification of kids with CP. And now that I'm in early intervention and not outpatient, I think it's something that we should be utilizing for sure.
I do it on pretty much every kid. Okay, so we have another question in here from Kate. Not sure if this is a question for Lauren or Kirsten, but what is the criteria that changes a child from at risk to having an official diagnosis of CP? Do you want to field that one, Lauren?
Yeah, sure. Sorry, I was like rushing to pull up this slide that I thought might pertain to that question. So I was a little distracted, but that's a really great question. Was it Kate? Yeah, Kate. So I'm just gonna show you this one slide. So it really, we're looking at those tools and then seeing how they are in each visit. So at 3 months of age, I just want to show you this slide real quick. Sorry, you're gonna see my whole box. It's not, can you guys see my screen?
Yep.
So as you can see, no, maybe this isn't the exact slide I wanted. Let me see. This one kind of shows it. Really, maybe it's on a different PowerPoint. I think it is this, but you can see that red boxes represent a cutoff score for CP-derived studies from this one article. But the window, this isn't the study I wanted, or the slide I wanted. But basically, what I did want to show you is that the variability in a Hines score decreases as a child gets older. So at that 3-month period, there's a lot of variability. So there can be a child that later has a typical neurologic outcome that may fall in our at-risk category. And so we just like to keep repeating those measures at each visit to see if they're consistently falling in the at-risk category, if their motor presentation is consistent with cerebral palsy before we make that transition from high risk, at risk to cerebral palsy. And then there is something that I do want to just touch on as well, that there's not necessarily a research study I have to go off of this. Hopefully in the future there will be, but this is more just anecdotally. there are a lot of children that have been high risk in the NICU, high risk at our first visit in neonatal follow-up clinic, and they get, they're on everyone's radar and they get so much therapy, kind of similar to this kiddo that Kirsten presented on, where they've got early intervention, motor therapy involved from an early, like the very beginning or as soon as possible. And from leaving the NICU, they immediately went to home health. And so they've gotten lots of very specific and appropriate therapy early on. And they stay in the at-risk category for a while because they're progressing so nicely. And we'll see like, oh, they've got to still have some tone abnormalities or neurologic deficits, but their testing is in the average range on their motor testing. So it's a lot of times, sometimes that category or that diagnosis of at-risk will last for a while, just depending on the child's progression. And I think really depending on their therapy, if their therapy is really effective and early, I feel like sometimes it takes us a little longer to diagnose because it's not as clear because they're doing so well. And so really it's just the consistency of those markers, those clinical tools. Obviously we can't repeat the GMA, but the HINE is so valuable and the motor testing is really valuable. And so it's just, are they consistently falling in that at-risk category? Is their presentation consistent with cerebral palsy? So oftentimes the more severe cases will get a diagnosis earlier, whereas the more mild cases, sometimes it takes us a little bit longer to be sure. Does that help answer your question, Kate? Maybe I was really long-winded or not enough detail, but.
And then I want to just ask a follow-up question, because you mentioned on those really at-risk kids that we all kind of are doing a lot of services. What about those kiddos that are looking really good and they tend not to do the follow-up NICU clinics, or they don't do that early intervention? How do we continue to monitor those kids without falling through the cracks?
That's a really hard question. One thing that's really interesting that we've seen here in neonatal follow-up clinic with some kids that are participating in our NRN study is for their 2-year visit, they do a big test battery, and they get a really great compensation for that visit. I think they get a gift certificate that's pretty significant. So we'll see a kid at 3 months adjusted age. They'll be at high risk. We'll recommend, if they don't already have early intervention therapies, we'll recommend that. But if parents aren't worried, sometimes they don't follow up with that. And then they return for their 2-year visit, and this child clearly has cerebral palsy and hasn't had services this whole time, or has had minimal services. So that was a really great question on how to avoid that. It doesn't happen all the time, but with the NRN, I think that study, we see some of those kids because there's a big incentive to come back for that 2-year visit. Whereas if there wasn't that incentive, they might just fall through the cracks until someone does refer them, as I think another PT was mentioning, to either PM&R, because it's obvious the child has cerebral palsy, but then they've missed out on this really important window for therapy. So I'm all ears if someone has an idea on how to keep these kids from falling through the crack. It's tough. We're all limited on resources for calling and following up on families, and our staff is limited. And, it's been tough with the pandemic, but does Pat have an idea? Yes. What's your idea?
Well, I get to see both ends of it all. And I also, in early intervention, get to pick up kids that are not coming out of an Intermountain facility. They're coming out of your HCA facilities. And the standard of discharge is very, very different. I had a 28-week gestation infant who I've been following. Mom called. Mom did all the work. And she never did call NFP, but as she was leaving the door, a nurse said to her, it would be really important for you to call early intervention, which she did. So every kid sees a primary care provider, or should. And I think that's where our big bang for our buck is to throw it at the pediatricians and say, fine, you're testing for autism, but can you also look at their motor system? And that's my suggestion, is our primary care providers.
I think that's a great suggestion.
That is a great suggestion. I mean, I think we all do child find, and I guess I was wondering, how do we incorporate some of that early identification within our child find systems or networks? So All great discussions, guys, to think about. We do have the discussion board on Canvas. If to keep this conversation going would be really great. I think it's a great way to learn how to support families and support our process and systems. So please, if you think about something, add that to that discussion board. I don't want to keep us past time, and we are at time, but great discussions, and I love hearing everybody's ideas and thoughts. Thank you to Lauren and Kirsten for sharing and presenting that with us. It's always a great one to remember to do. And then just a reminder that our next one will be June 1st with Sydney Ahlberg talking to us about feeding. Feeding concerns, how to help support that. So thank you again for joining us. Remember to complete your survey in your email.